whole life.
Good evening to all the delegates and our eminent speaker. Thank you all for joining this evening. I am Siddhant Sharma on behalf of Hetero Healthcare. Welcome you all for webinar on the introduction to bempedoic acid, non-statin lipid lowering agent in the management of uncontrolled LDL-C. As we agree, lifestyle disease in our country is on rise and it's surprisingly moving towards the chronic stage. We at Hetero Healthcare has always been at forefront along with your side to deal with such ailment. This evening, our esteemed and experienced doctors will share their experience on the subject. Before proceeding further, let me take privilege to introduce our eminent panelist. Dr. Shripal Jain. Dr. Shripal is the Director and Head of Medical Services at Medisecure Super Specialty Hospital and Nursing Home. He is also an Assistant Professor at MGM Institute of Health Sciences at Navi Mumbai. He has received several certifications such as ACLS, that is Advanced Cardiac Life Support, and BLS Basic Life Support certification from AHA in 2018 and 20. He has also participated in the state and national level of conferences like APICON and MAPICON, and also a member of organizing committee for conference of All India Gen Doctor Youth Conference in the year 2015 and in the year 2018. Feeling glad to introduce our second panelist, Dr. Keshav Kale. He is a senior interventional cardiologist at Apollo Hospital. He is a director at Khushi Heart Care and the Multispeciality Clinic, and also an assistant professor in Dr. D.Y. Patil School of Medicine. He has done the fellowship of FSCI, FESC, and AFACC, and also a member of National Academy of National Sciences. He is a co-author in well-renowned textbook in the 8th edition of API Textbook of Medicine, and also the Rheumatology Principles and Practice. He is also the life member of Cardiology Society of India, Indian Academy of Echocardiography, and Indian Society of Electrophysiology. So I welcome Dr. Shripal Jain and invite him to take over the session.
Unable to hear you, Siddharth.
Yes, sir, you're audible.
Okay. Yeah. So shall we go ahead with the session? Yeah.
Yes.
So good evening, everyone. So just one second. I'll start the PPT. I'm unable to share, just hold a second. Yeah. Just 1 second, sir. Yes, so today we will be talking about the session on bempedoic acid. So this basically best, that is BELRO scientific talk. So today we will be having a talk about this. Basically we'll start with the dyslipidemia. So dyslipidemia has a major impact on cardiovascular morbidity and mortality. And so burden on the rural and urban is quite high. So as 25 to 30% of the urban patient and 10 to 15% of the rural patient have burden of dyslipidemia, atherosclerotic cardiovascular disease. So the leading to this prevalence, leading to have desirable cholesterol level to maintain cardiovascular risk within the acceptable limit. Basically, we have to prevent and treat the dyslipidemia. It is an essential part for cardiovascular risk. So in individuals in the age group of 30 to 40 years have a high prevalence of dyslipidemia, which increases with further after the age of 60. In Indian patient, there is basically Indian patients are highly prone to develop atherosclerotic cardiovascular disease at an early age with more severe form, leading to poor outcome compared to the Western population. While the two-thirds of the deaths are due to non-communicable disease in India and are caused due to cardiovascular related conditions. So type of the cholesterols which we are see is total cholesterol range should be less than 170, non-HDL 120, LDL according to new guidelines should be less than 100, while HDL less than 40 or more than 45. So what are the challenges and current challenges and gaps in the cholesterol management? From the cardiac point of view, I would ask Keshav Kale sir to give some insights about the same in their own way. Hello.
Hello.
Yeah.
Yeah. If you see the cardiac from point of bempedoic acid or some other lipid lowering drugs, I think cholesterol is closely related to heart. Basically, cholesterol is equal to the heart. So if you see, there are multiple levels of cholesterol, multiple types of cholesterol like LDL cholesterol, non-HDL cholesterol, HDL, and lipoprotein small a. If you see, most important thing is LDL cholesterol, LDL-C cholesterol, dense lipoprotein. So LDL-C is most important, then followed by it is a non-HDL cholesterol, and then the triglycerides, and then lipoprotein small a. So there are some current challenges and gaps in the cholesterol management. So if you see the ESC guidelines, uncontrolled LDL-C guidelines, LDL cholesterol plays a key role in the development of atherosclerotic plaque, subsequently cardiovascular events. Many patients with hypercholesteremia remains above the guideline recommended LDL-C. If you see in the clinical practice, if patient has acute coronary syndrome, put on the highest dose of the statins, like 80 milligram atorvastatin or 40 milligram rosuvastatin. Despite of all this treatment, whatever the treatment, maximum dose of the statin which is tolerated, and sometimes we add the drugs which are not statin, but they inhibit the cholesterol absorption. There are different mechanism of action from the statins. Still, there are levels of LDL-C. I think near about only 40% of the patient, in spite of having the highest doses, they have LDL-C in the less than 70 or less than 50, what is the desired level. So in spite of all this treatment, approximately 50 to 60% patient never achieves the LDL-C level. And I think that is the fact. Because once we do the procedure like coronary angioplasty or coronary angioplasty, we just forgot the cholesterol level. Just we are done the procedure, patient also forgot the cholesterol level, many times doctors also forgot the cholesterol level. So many times these patients are not many times adequately managed, or not adequate doses are maintained throughout the next career and next after the first index event. Many times patient has intolerance to the cholesterol levels, and there are so many gaps for the management of LDL-C. So for that purpose, I think it is very, very difficult to manage the patient post cardiac event at the cholesterol perspective, because they have multiple issues with the treatment with the cholesterol. And if you see the effect of cholesterol, I already told cholesterol is equal to cardiology. So if you see, there are high level of cholesterol and high level of triglycerides, both the factors along with other coronary risk factors like high blood pressure, smoking, insulin resistance, obesity, or diabetes. All these factors all these factors comes together and they forms the plaque formation in the coronary arteries. Initially, there is only fat deposition and mostly come LDL-C, then there is a macrophage activation, then comes smooth muscle cells, and ultimately patient there is a large plaque burden in the coronary arteries and luminal stenosis, and that leads to severe atherosclerosis and patient develop the cardiac event. Next. So if you see, why I'm saying that there are multiple options till now how to manage the cholesterol level or LDL-C, mainly LDL-C. There are so many drugs available in the market in spite of having this therapy. At least for 50% of patients, there is no control of LDL-C. So if you see, the first important drugs are statins, because if you see, the statins are mainly act as the HMG coenzyme inhibitors, and they act as the liver level or LDL receptor level. And there are multiple statins like atorvastatin, rosuvastatin, simotinib. Many of these are available in the market. Then another drug I already told, the drugs which has a different mechanism from the statins, like they inhibit the absorption of the cholesterol from the intestine, and this is called a cholesterol absorption inhibitors like ezetimibe. These are the drug and that limit the absorption of the cholesterol from the gut. Then there are many drugs like bile acid binding regimens like cholestyramine or cholestyramine. All these drugs reduces the cholesterol. Then recently there is the PCSK9 inhibitors because like evolocumab and alirocumab, they act at the level of the liver and then they can help the liver absorb more LDL cholesterol, and this is basically acting at the level of liver only. Then there are drugs like fibrates like fenofibrate, gemfibrozil. These drugs are basically used for the reducing the triglyceride levels. They sometimes reduce the LDL also, but basically they are related to VLDL and triglycerides. Then niacin has a multiple side effects, and specifically they are used to limit the liver's ability to produce LDL and VLDL cholesterol, and many times there is some elevation of the HDL level also. And omega-3 fatty acid supplements are some supplement to the associated with statins and other drugs. But if you see another drug which is marketed in 2020, is the most important ACL inhibitors. Is called Bempedoic acid, and that reduces the cholesterol. It acts basically at the liver level, and in the cholesterol synthesis pathway, it acts simultaneously along with the statins. So this we'll see today the what is ACL inhibitors or bempedoic acid, and then accordingly we see what are the drugs drawbacks and mechanism of action and all supporting evidence for using the drugs in the cholesterol lowering therapy. So if you see uncontrolled LDL levels, see, as per the cardiovascular drug therapy 2021, up to 80% of the patients treated with the statin do not achieve an optimal LDL-C level because of high baseline LDL-C level, aggressive LDL-C treatment goals, lack of sufficient statin therapy, and poor statin persistence or adherence. I already told. Many patients are not achieving the LDL-C level post-cardiac event or primary or secondary prevention. That problem is basically where we are not starting the sufficient dose of statin. Many times patient has intolerance to the statin, and sometimes there is a problem with the adherence due to the economical problem or some other problem. So anyway, many patients are not reaching the target goal required for LDL-C in primary and secondary prevention. So adverse back.
Sorry.
Yeah. The adverse effect primary muscle symptoms can limit the maximal tolerated statin dose to low dose therapy and may make the patient not adhere to their treatment or stop their statin therapy. The side effects of the statins, I think in many patients has culprit factor for decreasing the dosage of the statin therapy. So what are the challenges with the statin therapy? Why this statin therapy is not sufficient, only sufficient for the management of the dyslipidemia or hypercholesteremia in the patient who has needs primary prevention or secondary prevention in a cardiac perspective of view. So if you see residual risk, in spite of, if you are using statins to reduce the atherosclerotic cardiovascular disease risk by 15% to 37%. However, residual cardiovascular risk of 60% to 80% still persists despite optimal statin treatment, and this is linked to the major vascular event in about 20% of patients with coronary artery disease. So if you are putting the patient on the cholesterol lowering drug like statins, still really residual risk, and many patients they may end up into the recurrent coronary events due to the residual risk. Then second problem or challenge with the statin therapy is non-attainment of LDL-C target. I already told, in many patients, in spite of the giving maximal doses of the statins, I think only 37% of the patients with coronary artery disease are there achieve the target level of the LDL-C. So at least for 60% of the patients, in spite of giving maximum doses of the statins, they are now achieve the LDL-C level. And third problem with the statin therapy is non-adherence. Non-adherence, basic most important things for non-adherence is basically for the side effects of the statins. Many patients have developed the myopathy or myotoxicity. Patient develop the muscle cramps. Sometimes patient develop the hepatotoxicity, and that lead to the stopping of the statin therapy in the patient who are taking for the primary or secondary prevention. So if they are taking the statins, there is always residual risk. Then there is a non-achievement of the LDL-C goal, and patient may have statin intolerance. So most important side effect of the statin is muscle problem. Patient develop the myopathy or myotoxicity due to the statin because these HMG coenzyme inhibitors basically they have substrate in liver and muscle also. So when they are acting at the liver level, they also act at the muscle level, and patient develop the muscle weakness and myopathy. I think that is a major issue with the statins. So if you see the uncontrolled LDL-C level, then there is a need to new add-on treatment which would help reduce the hypercholesterol. The only statins are not sufficient for the management of LDLC. It requires some help of the other drugs which have different mechanisms. Next. So I think we are going for the newer drug which is available now for the lipid lowering therapy, which is non-statin. It is called Bempedoic acid. So Bempedoic acid is a drug used in conjugation with the lifestyle modification or other agent for the treatment of refractory hypercholesteremia. If your patient is taking statins for the highest dosage or tolerable doses, still LDLC or cholesterol level is high, I think drug has efficacy in reducing the cholesterol level. And this class of the drug is lipid lowering agent. It is HCl inhibitor, and it is oral drug, and dose is 180 milligram per day. It is a standard dose for the Bempedoic acid. For Bempedoic acid, I think pharmacokinetics is mostly important, because if you see absorption of the Bempedoic acid is rapidly absorbed in the small intestine, there is no effect of the food. You can take with food or without food, there is no issue of the food on the viability of the Bempedoic acid. Then second important part with Bempedoic acid is, if you see the half-life of the Bempedoic acid is 15 to 24 hours. That means we can give the drug as a single daily dose or OD doses we can give into the patient because of long half-life. Then plasma protein binding capacity is near about 99%. The drug is attached to the plasma protein. And if you see the metabolism, Bempedoic acid is reversibly converted to active metabolite. Bempedoic acid is not active drug as such from we are taking orally. Then it goes to the gut and then it is converted to the active form in the liver or in the kidney, and that active form is only specific for the lipid lowering therapy. So it is a prodrug. It is not an active drug when you are giving to the patient. And excretion of this Bempedoic acid mainly is from the urine, 70%, and 30% from the feces. So this is a mechanism of action. I will not go in detail, but if you see the action, and before going for the action, if you see the formation of the cholesterol, how cholesterol is formed. The cholesterol is mainly formed in the liver, and basic substrate for the cholesterol formation is citrate. This citrate convert into the acetyl coenzyme A. This acetyl coenzyme A convert into HMG coenzyme A, and this HMG coenzyme A convert into malonic acid, and malonic acid convert to the cholesterol. This is the pathway. It is called TCA pathway, a TCA cycle for the cholesterol synthesis. Yes. So if you see the Bempedoic acid, I already told Bempedoic acid is a prodrug. It is not active drug. So this prodrug, Bempedoic acid, in the liver and kidney, the substrate for the conversion of the Bempedoic acid prodrug to active drug is liver and kidney. So this Bempedoic acid is converted to the bempedoyl coenzyme A. This is active form of the Bempedoic acid, and this is converted by the ACSVL1 synthesis enzyme. This ACSVL1 enzyme is convert product to active drug. So if you see the pathway of TCA pathway for cholesterol synthesis, this Bempedoic acid acts as the first step. When citrate is converted to the acetyl coenzyme A, this conversion is blocked by the Bempedoic acid. So there is a basic first step of this TCA cholesterol synthesis pathway is blocked by the Bempedoic acid. And next step is when it converts from HMG coenzyme A to the malonic acid, this is blocked by the statins. So in this pathway at two stages, there is a blockage of the cholesterol synthesis. So these two drugs, statins and Bempedoic acid, not a similar action, but they have act at a different level of the cholesterol synthesis pathway. And this action is synergistic to each other. That's why this combination of statins plus Bempedoic acid works very aggressively for reducing the LDLC level. Next. So this is regarding the pathway for the action of the Bempedoic. I already told all these things. Mainly it acts, mainly this Bempedoic acid, previous slide, mainly why this diagram is important. If you see this action of the Bempedoic acid is mainly in the liver and kidney, but the action in the skeletal muscle is very, very less, because this enzyme ASCLV1, the conversion of the prodrug to active drug is less in the skeletal system. So chances of myopathy and muscle problem or muscle cramps or myopathy, myotoxicity are very, very less with this Bempedoic acid. The only issue of the Bempedoic acid is related to the Bempedoic acid when there is a OAT2 receptor activation that increases the uric acid level. That is the only issue with the Bempedoic acid. Otherwise, if you see the action of the Bempedoic acid is strictly related to the liver and kidney and very less to the skeletal muscle. Next. So this is same like ACSVL1 enzyme. This enzyme is important for the conversion of prodrug to the active drug. So this enzyme is expressed mainly in the liver and kidney. That's why the prodrug is converted to the active drug in the liver and kidney in majority. But in skeletal muscle, other tissue, this activity of this enzyme is very, very less. So that's why this action of the bempedoic acid is restricted to mainly liver and some amount to the kidney. Other sites are very less exposed to the bempedoic acid action. That's why there are no muscle weakness, there is no myopathy, as there are prevalence in the statins. These chances of side effects are very less with the bempedoic acid. That's why that increases the medical adherence, increases the patient's tolerance or compliance to the treatment for the lipid lowering therapy. So activity of the statin in the muscle potentially contribute to statin associated muscle symptoms that occurs in some patients, resulting in poor. So the statins basically acts at the liver level also, acts at the skeletal muscle level also. That's why there are the side effects are very common with the statins, and this action is less with the bempedoic acid. So myopathy and myotoxicity is very less with the bempedoic acid. Next. So when FDA has approved bempedoic acid, if you see, bempedoic acid has received first approval in the USA as a monotherapy on 21st February in 2020. And if you see combination with ezetimibe, it is approved on 26th February 2022. Approximately near about 2 years over for the after the FDA approval for the bempedoic acid. And mainly this bempedoic acid is approved by US FDA for two conditions. One condition most important is heterozygous familial hypercholesterolemia, and second is established atherosclerotic cardiovascular disease in which LDL-C level is not achieved at the target level. Next. So this is a bempedoic acid as a monotherapy. If you see in patient with dyslipidemia and in patient with type 2 diabetes mellitus and in patient with dyslipidemia and hypertension, in all this level, I will go again next slide for the evidence, but in this there is significant reduction of the apolipoprotein B. Apolipoprotein B is always associated with the LDL-C. It is precursor of, it is a lipoprotein associated with LDL-C. So bempedoic acid reduces the apolipoprotein B. It reduces the LDL-C. Many times we as a clinician always forgot non-HDL-C. I think non-HDL-C is as important as the LDL-C. So target for the cholesterol or lipid profile, where to target first LDL-C, then where to target non-HDL-C, then target triglycerides, and then HDL, and last lipoprotein small a. So these are the 4-5 targets in the lipid profile. So many times we are forgetting the non-HDL-C. I think it is more important as the LDL-C. So bempedoic acid reduces that. It reduces HSCRP. If you see the patient with diabetes, there is a great benefit from the bempedoic acid. There is a 43% reduction of LDL-C, 41% reduction of HSCRP, because HSCRP is a marker of inflammation, and atherosclerosis is one of the indicator for the inflammation. So in patient with dyslipidemia and hypertension, there is also significant decrease of LDL-C by 21% and 25% decrease with the bempedoic acid. So all the patients with dyslipidemia and diabetes, bempedoic acid is beneficial for reducing the LDL-C and CRP. Next. So how will you use the bempedoic acid? Whether bempedoic acid is monotherapy or use with the combination. I think still now evidence is where to use the bempedoic acid along with the combination, and most important combination is statins. So if you are use the bempedoic acid with combination with the statin, it reduces LDL-C by 22%, and it is safe and effective along with the statins. Means it doesn't increase the side effect of the statin, or doesn't produces the more myopathy and myotoxicity as compared to the only statin. So it is a safe and effective along with the statin therapy as add-on therapy. Okay, next. So what is the bempedoic acid indications? I already told there are 2 indications for US FDA approved this bempedoic acid. Most important is hypercholesterolemia, and it is indicated as an adjuvant to the diet and maximally tolerated statin therapy for adult with heterozygous familial hypercholesterolemia. And second indication is established atherosclerotic cardiovascular disease who requires additional lowering therapy. Means there are 2 indications. One indication mainly the heterozygous familial hypercholesterolemia, because if you see, we are using the statins in heterozygous familial hypercholesterolemia. In spite of using high dose of statin, I think we can't achieve the LDL-C level, target LDL-C in the familial hypercholesterolemia. But this indication I think is good for the bempedoic acid. And second is, if patient has already established cardiovascular disease or coronary artery disease, and you are not able to achieve the target LDL-C, then I think we have to use the bempedoic acid. Dose of the bempedoic acid, already told, it is 180 milligram once a day. Next. So what are the drug interaction? What precautions we have to take with the bempedoic acid? I think there are two precautions. One is because this combination is always with the statin. Bempedoic acid added with the statins. So you should know that when you are using simvastatin, I think the dose of simvastatin should not be more than 20 milligram. And when you are using with the pravastatin, I think your dose should be not more than 40. And if you want to increase the dose of statins along with the bempedoic acid, I think we have to convert from simvastatin and pravastatin to either atorvastatin or rosuvastatin. Okay. Then there are some peculiar conditions. Can we use the bempedoic acid? If you say pregnancy, I think bempedoic acid there is no support for using the bempedoic acid in the pregnancy. It is mostly contraindicated. But if you want to use, then the benefit of bempedoic acid should overweight the risk in the pregnancy. Lactation and in pediatric use, actually there is no supporting evidence for using the bempedoic acid. You should not use it during lactation, and you should not use it in the pediatric cases. Then what are the side effects? Because always we are seeing the lipid lowering therapy as a statin only. So I already told the statin most important problem is the myopathy and intolerance to the drug. But if you see the bempedoic acid, I think there are chances of myopathy are very, very low, and that phenomena is only useful for using the bempedoic acid along with the statins. So most common side effect of bempedoic acid, I think, is upper respiratory tract infection and then hyperuricemia. I already told O2 receptors that are activated by the bempedoic acid. That's why this hyperuricemia and gout, I think this is the main problem with the bempedoic acid. Other side effects like back pain, abdominal pain, bronchitis, pain in extremity, or other elevated liver, that's a minor effects. But most common effect is hyperuricemia. Okay. So this warning I already told, hyperuricemia, elevation in serum uric acid level occurred, and assess uric acid level periodically, because uric acid level we have to assess periodically if there are symptoms of gout. Then I will go shortly to clinical trials. I will not go in detail, but there are multiple clinical trials like clear SERENITY trial, clear wisdom trial, bempedoic acid and hypercholesteremia trials, then clear harmony trials, clear tranquility trials, and so many trials. So I will go shortly for some important trials. So this is the clear SERENITY trial, means cholesterol lowering by bempedoic acid and ACL inhibiting regime study. In this study, what they have done, they have seen the efficacy, safety, tolerability of bempedoic acid 180 milligram daily versus placebo in statin intolerant patient requiring lipid lowering therapy for primary and secondary prevention. So in this, they are use the patient who are statin intolerance. So they are done the study in 345 patients with hypercholesteremia. Mean age of this patient was 65 years. And then primary endpoints was mean percent change from baseline to 12 week in the low density lipoprotein level, LDL-C level. Primary endpoint was reduction of the LDL-C level at the 12 weeks. So what they found? Bempedoic acid was safe and well tolerated. The most common side effects or muscle related adverse effect was myalgia and occurred only in 4.7% of the patient who received bempedoic acid. So it is safe and effective reducing the LDL-C. So this is another trial. It is clear harmony trial. What they have studied the safety and efficacy of bempedoic acid and treatment in long-term studies involving the patient with hypercholesteremia who are receiving guideline-directed statin therapy. So first study was statin intolerance patient, and this second study is clear harmony trial. They are saying that patients are taking the statin therapy. So adding this bempedoic acid along with the statin, how it affects the LDL level. I think this is the aim of this study. So in this, they have studied the more than 2,000 patients whom more than 1,500 were assigned to receive bempedoic acid and 742 receive placebo. The primary endpoint of trial was overall safe, which was assessed according to the incidence of adverse event. At 12 week, bempedoic acid reduced the mean LDL-C cholesterol level by 9.2 milligram per cent. So in this trial, they found that in 52-week trial, treatment with bempedoic acid added to maximally tolerated statin therapy did not lead to higher overall incidence of adverse event. Means it is safe and effective therapy, and there is effective reduction of the LDL-C also as compared to the placebo. So message from the clear hormone trial is that at 52 weeks, this bempedoic acid is safe therapy. There are no increase in the side effects. And second is effective therapy because there is significant reduction of LDLC by 20 milligram percent at 12 weeks. So this is a safe and effective drug. Then another, this is a clear wisdom trial. This is effect of bempedoic acid versus placebo added to maximally tolerated statin on the lower. I think it's similar like a harmony trial. In this, they found that 800 patients with atherosclerotic cardiovascular disease, heterogeneous familial hypercholesterolemia included, and they have studied at 2 weeks. What they found? Among the patients of high risk for cardiovascular disease receiving maximally treated statins, addition of bempedoic acid compared with the placebo is significant reduction. Means patient has high risk for the cardiovascular disease. They have selected in this trial. They have put on the maximal tolerable dose of the statins. And after that, this is the inclusion criteria. And after that, they are divided into two groups. One group they have put on the bempedoic acid group, and second was placebo group. So as compared to the placebo group, there is significant reduction of the LDLC over 12 weeks. I think that's why there is a adding of the bempedoic acid over the maximum tolerable dose of statins is safe and effective. Next. So this is a clear tranquility trial. This is basically used to evaluate the efficacy and safety of bempedoic acid when added to the background lipid modifying therapy in patients history of statin intolerance who require additional LDLC. So in this, they have used the bempedoic acid in the patient who has intolerance to the statins, and they have compared bempedoic acid versus placebo, and they found that bempedoic acid was well tolerated and may provide oral therapeutic option complementary to ezetimibe in statin intolerant patient. Means if patient is not tolerating the statins, bempedoic acid with ezetimibe I think will be a good option for the treating patient for the LDLC reduction. Next. So this is the diagrammatic. I say all this study, clear harmony, clear wisdom, tranquility, and clear city. All this study, there is a significant reduction of the LDLC with this bempedoic acid, and there is only minimal side effect, or there is no increase in the side effects of the statins along with the bempedoic acid. Next. So if you see key pointer for bempedoic acid, no concern. No concern means many drugs are contraindicated in patient who has renal failure and hepatic failure. But if you see bempedoic acid, unless until there is severe renal end-stage renal disease, there is no need to change the dose of the bempedoic acid. In hepatic impairment also, if it is mild or moderate, we can safely use the bempedoic acid. Only patient has stage C hepatic failure or a child pro class C, then and then only we have to stop the bempedoic acid. Means it is safe in the renal problem, and it is safe in the hepatic problem. There is no need to change the doses also. Then in some condition, when you are using bempedoic acid, we have to monitor basically uric acid. I already told uric acid is the only problem along with the bempedoic acid. So we have to be very, very careful in patients who has already hyperuricemia, or when the patient develops the signs and symptoms of gout. So periodically we have to monitor the uric acid level. I think that is the only issue with the bempedoic acid. And when to discontinue the drug, another one problem with bempedoic acid is usually tendon rupture, or there is a problem with the cartilage and tendons. So if patient's age is more than 60 years of the age, and patient taking corticosteroids or fluoroquinolones, or patient has renal failure, or patient has previous history of tendon rupture, then I think it is not advisable to start the bempedoic acid. Then if patient is taking already simvastatin or pravastatin, that doses more than 20 and 40 milligram, I think is avoid to add the bempedoic acid along with the higher doses of pravastatin and simvastatin. And already told pregnancy and breastfeeding, I think there are contraindication. I think there are no supporting needing to use the bempedoic acid in pregnancy and breastfeeding. Next. So this is a bempedoic acid in hypercholesterolemia. Next 3-4 slides. So this is the object to conduct the pooled analysis of phase 3 randomized trials of this bempedoic acid. They have used the bempedoic acid 180 milligram OD and placebo versus 12 to 52 weeks. Because why this is important? Because in familial hypercholesteremia, I think always resistant to the statin. All these drugs used for the lipid lowering therapy, and in that this type of familial hypercholesteremia is resistant. So I think the primary endpoint for using this bempedoic acid hypercholesteremia was percentage change from baseline LDLC at 12 weeks. Next. So this is, if you see, at 12-week LDLC level percent change from baseline was 16%. There is 16% reduction with the LDLC level with bempedoic acid and only 1% with the placebo. So bempedoic acid added to maximally tolerated statin, including moderate to high statins, no background statins, was associated with decreased LDLC versus placebo in hypercholesterolemia with acceptable safety profile. So we can use bempedoic acid on the maximum dose of statin, and we can use a bempedoic acid without statins also who are intolerant to the statins, and that significantly reduces the LDLC level. Next. Then bempedoic acid in the type 2 diabetes, pre-diabetes and normoglycemia. Next. So if you see this diagram, I think it's important diagram because
Yes.
in the patient with diabetes and pre-diabetes, bempedoic acid significantly reduce the HbA1c. Because if you see the use of statins in patient who doesn't have diabetes, the patient with acute coronary syndrome using the statins higher dosage, I think some patient develop the pre-diabetes, some new onset diabetes mellitus. So there is always glucose intolerance when you are using the high dose of statins. But if you are using bempedoic acid, in contrast to the statins, I think there is a reduction of HbA1c 0.1 to 0.06% if patient is diabetic. But if patient doesn't have diabetes, I think there is no increase in the glucose level. Means this bempedoic acid in diabetic patient, there is no problem with the sugar level, and there is no change in the HbA1c. In fact, there is some reduction of HbA1c as contrast to the statin. If patient does have a pre-diabetes, the chances of conversion from pre-diabetic to diabetes is also not common with the bempedoic acid. And if patient doesn't have diabetes or normoglycemia, the development of the new onset diabetes mellitus or pre-diabetes is very rare. So I think bempedoic acid for 1 year did not worsen glycemic variables or increase incidence of few new onset diabetes as compared to the placebo. It is safe drug in perspective of the sugar level. Next. So at the end of this topic, if you see the bempedoic acid, it is a novel lipid lowering drugs, and basically it acts, mechanism of action is inhibit the ACL enzyme, that is the enzyme which is essentially in the first step with the cholesterol synthesis. Second, add on with maximally tolerable statin for dissolved LDLC level target is helpful because it is well tolerable combination with the maximum dose of statins. There is no increase in side effect, but it is also effective because there is significant reduction of LDLC over the statins. Then it reduces the apolipoprotein, because apolipoprotein B is a protein for the LDLC. So it reduces apolipoprotein B. It reduces hsCRP, which is a marker of inflammation. And lastly, and most important, it is safe. It doesn't produce myalgia. There is only minimal drug-to-drug interaction. Most of the time, we can give the drugs to all the patients who are taking other drugs. And it is safe in the renal failure. It is safe in the hepatic failure also. Next. Thank you.
Thank you, Keshav sir, for the brief explanation about the same bempedoic acid. So, with the clinical practice, I would like to have some questions regarding the same. So, sir, how is your experience regarding the using of bempedoic acid in your practice, sir, daily?
Yeah. Now the bempedoic come in the market recently only. We have only few patients with the bempedoic acid, but I think it will require the long-term follow-up of the patient for see the how it reduces. If you see the trials, there is a significant reduction of LDLC. But as the individual practice, I think it requires the more experience with the bempedoic acid. For sure, sir, one thing is chances of myopathy and myalgia, I think are very, very less. I think that is a major issue with the statin therapy.
Right, sir. So, sir, there are a few questions which we have got. As we have already cleared about it, that can bempedoic acid can be used as a monotherapy or in any specific class of the patient where it can be used as a monotherapy.
Yeah,
so,
correct.
would you say that it can be used as a monotherapy as well?
Yeah, correct. So I already told you, US FDA is approved in 2020,
Yes,
in
sir.
February 2020 as a monotherapy only. But they are added with the ezetimibe also. Then again, it comes with the combination therapy. So we
Right,
can,
sir.
if patient has an intolerance to the statins therapy, bempedoic acid as monotherapy also effective along with the ezetimibe. We can use it monotherapy also. If you can't use the statin therapy, there is no issue at all.
Right, sir. So, sir, do you like what have you observed any changes in the lipid profile for post-COVID patients who are already on, and have you significantly have gone through any such profiles where lipid profile post-COVID, any significant changes has been observed?
Actually, there is no evidence, strict evidence or studies for the
Yes,
change
sir.
in the lipid profile in post-COVID. But if you see the evidence of the coronary artery or coronary events in the post-COVID condition, they are high. Whether these are related to the lipid levels or whether these are related to the prothrombotic state, I think this is the question mark. But still,
Right, sir.
there is increase even of the cardiac event in the post-COVID. That is 100% sure.
The patient who are with, like, for our clinical practice where we in diabetic patients, when we give statins alone or sometime with the ezetimibe also.
Yeah,
so rather than starting on statins, because patients are sometimes reluctant to continue the statins because they are already on so many medicines for diabetes itself. So to put them on a bempedoic acid, so as a monotherapy, you would recommend that, or we should be going with the statin only, because that will give a better benefit for the cardiovascular event related to diabetes.
Yeah. I think at present the evidence is basically add-on therapy with the statins only. If
Right, sir.
it is tolerating the statins therapy and not receiving, not achieving the LDLC level, I think bempedoic acid give you. But in some patient, if patient is not tolerant to the statin at all, if you are not using the statins in spite of small dose also, I think the monotherapy with this bempedoic acid along with ezetimibe is the best combination to reduce the LDLC.
Sure, sir. Thank you, sir.
Yeah.
Siddharth?
I think firstly, thank you very much, sir. It was indeed a pleasure and honor having you taking this webinar. And on the behalf of Hetero Healthcare, we would like to extend our thanks for your comprehensive session on bempedoic acid. And we are sure our delegates got enlightened regarding this topic, as we have covered all the aspects of it. And I also like to thank to all the participants and other attendees for their warm presence. Thank you very much, Doctor, for joining with us.
Thank you. Thank you, Shripal. Thank you, Siddharth.
Thank you, sir. Thank you, sir. Thank you.